I think this is also the time where I have to talk about my disclosures. And I want to start off by saying that I have no financial disclosures because nothing I do actually pays me any money. But I do have a personal disclosure. I was born, my mom had placenta previa, so she needed an emergency C-section. When I was 2 months old, I had pyloric stenosis and needed a pyloromyotomy. When I was 23, I had appendicitis and had an appendectomy. I was fortunate. I had access to care. I'm here today. There are a lot of people in that similar situation who would be dead right now. And I think there's a lot that we can do to really help a lot of these people. Now, when I got an email from Ray, and I forget what location I was in when I got it, and he was asking me to do a talk on working with ministries of health and WHO, I thought, well, you know, I've been doing this kind of work for about 20 years, so yeah, I guess I'm, you know, qualified to talk about it. And I thought, you know, what exactly am I going to talk about? And I said, well, you know, maybe I can give some lessons learned. But really one of the things I thought was, you know, I'm big on social media and Twitter. I said, well, you know, I'm just Adam, I'm just a simple surgeon, but, you know, one of the people I can contact is the Minister of Health of Rwanda, because she's on Twitter all the time. And so I tweeted her and I said, you know, I've been asked to give a talk on working with ministries of health. Do you have any advice, comments, or suggestions? And she said, just tell your experience. So that's what I'm going to do today. I'm going to talk a little bit about my experiences and try to share with you some of the things I've learned, some of the good and some of the bad, in working in a lot of difficult places with really a lot of local experts. I learned a long time ago, I'm not the expert, I am the expat. The local guys are the experts. But one of the things I want to start with is sort of, I show this because basically everything I've ever learned, I learned from The Ugly American. And I don't know how many of you have read this book, but really you need to. And unfortunately, the lessons in the book keep happening over and over and over. It was written in 1954 about a fictitious Southeast Asian country and talks about what happens there. I won't spoil the ending. There is a hero. There are some good points, and I think it's really a good place to start. But for this, I'm going to start now in Malawi. And this is Kamuzu Central Hospital. It's the largest hospital, or actually it's the second largest hospital in Malawi. It's the only general, it's a tertiary care center for the central part of Malawi. It's the only hospital really doing surgery for about 5 million people. And this is where I went when I started doing international surgery, global surgery. I had just finished my training. I'd finished a residency. I knew everything. I was good. I went here and within a couple of weeks, everyone kind of hated me. And I was doing it wrong because I didn't really understand the context. I didn't understand the limitations. I saw the way we did things in the US, but this was Malawi. This is one of the poorest countries in the world. And so I took a step back and I said, let me observe, let me see what can be done. Let me see what's happening. And one of the things that was really fascinating for me is, because I kept going back, been there about 6, 8 times. One time we were sitting down with the Ministry of Health and they asked for a list of supplies and equipment that they should purchase for the next year. And they said, you know, those Ethicon sutures you guys love so much, they're really expensive. So do you mind if we get the Indian stuff? Not to pick on India, but it was cheaper. And we said, sure. Yeah, you know, let's try it. Let's see how it is. Let's save some money. You know, this is Malawi, and it's a poor place, and we're doing surgery. Maybe this is the way to go. After about a year of using the sutures, we found that they really weren't very good. They were breaking. It wasn't the quality that we wanted. And so we went back to the Ministry of Health after a year and said, you know, this cheaper stuff doesn't work. And they said, oh, okay, you can get the more expensive. And it kind of blew me away. from the realization that, you know what, these governments and ministries of health, there is money there, and people have to make priorities. And so I'm not a big fan of sending over supplies and equipment, because if I send over supplies and equipment, they're going to use the money they have on other things. And people need to really figure out what are their priorities. And it's not really up to me to dictate what priorities are. But it was a fascinating observation. I'm going to switch now to South Sudan. And this is the Nile River in the town of Malakal. It's beautiful in this picture. Reality is maybe a little different. I was there, ended up treating cholera. There was a cholera outbreak. I was working with Doctors Without Borders. And there was also Doctors of the World were there. And because of the huge outbreak, we needed to set up a cholera treatment center. And so we did it in the local football stadium. And it was great. It was a big area, it was enclosed. We could have security and monitor who was coming in and out. And the outbreak went on for about 2 or 3 weeks. And then there was another organization, Doctors of the World, came in. They wanted to set up another cholera treatment center, so that was started at a school. And the number of cases started to come down, but they didn't disappear. And then the Ministry of Health said, okay, we're going to close the cholera center at the football stadium. And we said, well, but you can't. There's still cholera. We have to take care of these patients. And they said, no, but you don't understand. It's football season, and that's much more important. And so we went back and forth to try to negotiate, and ultimately they won because it was more important for them. And again, it showed me that I may know the textbook, I may know this is a great place, but in the context of the setting, what I thought was wrong, they knew best. This is in Dakoro, this Dakoro District Hospital in Niger. It's kind of the middle of nowhere. It's 12-hour drive east of the capital Niamey, and then about a 4 or 5 hour drive north. My wife, Rana, was there working with Doctors Without Borders. She was the only person doing emergency obstetrics at this district hospital for a catchment area of about 500,000 people. She was there for 9 months. I had some time. I actually knew a surgeon from Niger, and I said, hey, Dr. Sani, what do you think? Is it possible for me to go work in this hospital to train and do some emergency surgery and to help out, not with Doctors Without Borders, but sort of independently. And he's running a project where they're training local doctors to do emergency surgery. And it's a very successful project. So he said, great. So I was there visiting. Rhino had her vacation. We went to the Ministry of Health. They said, everything's fine. Show me your CV. I gave him a copy of my CV, my certificates. It's great. When you come back in 2 months, you'll have a letter. Everything will be good. I came back in 2 months. I hear a laugh. There was no letter. And they said, well, the minister's out of town, but next week you'll have a letter. So I said, okay, fine. So I went to Dakoro, and I sat there, and I waited for a letter, and I waited for a letter. And after 2 months, a letter never came. And other people had said to me, well, there's a need. You should just go. Go and start working. And I said, no. I said, there is a government here. There is a Ministry of Health. There must be some process, and I am not going to go on my own to start operating. Now, it turns out that there was a political issue going on. The program to train the doctors was out of the president's office, and it was very successful, raising a lot of money. It was not part of the Ministry of Health, and the Ministry of Health just didn't want to give more credit to this surgeon. Again, not my country, not my problem, really. Disappointing, yes, but one of the things you try to do when you're in these situations, and it can be frustrating, is you make the best of it. So one of the things when I was sitting there, I was thinking, wow, there are a lot of C-sections going on, because Rhino was really busy. And I bet if you look at the logbook, you see all these C-sections, and you see no general surgery. But I know there's a need for general surgery. So I said, I wonder if you started to look at data globally and compared the number of C-sections that are done to the total number of operations that are done. Because in a lot of places it seems like people are going to do C-sections. There's a need for it, they know how to do it, they do it. But maybe they won't do the hernias, maybe they won't do the appendectomies or the abdominal operations. And so because of that, and I had the time, we were able to look and come up with a quick indicator to say, yeah, it does kind of work that way. In OECD European countries, of all the operations that are done, it's about 2.5% are C-sections. If you go to Sierra Leone, it's about 40% of all the operations are C-sections. Uganda, it's about 35%. Malawi's a little bit better, about 24%. John Mara, Chris Hughes just looked at Haiti. There was an increased percent as well. So again, yes, I could have gone to the hospital and probably operated, but hey, they're a country. This is Conrad Hospital in Freetown, Sierra Leone. It's the largest hospital in the country. I do a lot of work there. I work a lot with the local surgeons, Dr. T.B. Kamara. One of the things we do is we try to support them in their work. And part of doing that is also helping them to publish the work that's being done. So we've published about 6-8 papers. Also what's important is it's a government hospital. It's a Ministry of Health hospital. So whenever we come and visit, Dr. Kamara says, let's go visit the Minister of Health. And I'm always thinking, why? Why do I need to go visit the Minister of Health? You know, he's a busy guy, woman now, but that's the process. The other thing is when we're writing up all of our papers, we include the local surgeons, we include the folks at the Ministry of Health, because it's their data, it's their work. They review all of our final copies, they see what's going on. But what's even nicer, and this is a chart from a paper that was just accepted and will be published in the World Journal of Surgery. We did assessments of the surgical capacity in Sierra Leone. And what we did was we repeated the assessment. We did it initially in 2008 and we repeated it in 2011. And it's great, we'll get another publication, which is nice for an academic career. Unfortunately, I don't have one, so. But anyway, what actually makes me really happy is, well, you see, first of all, on the left, you see the increases. The white bars are 2008, the black 2011. So you see that in the capital city, Freetown, things are doing better. In the districts, not so much. But in talking to the chief medical officer, what he said was, because of this data and this study, he went and checked out the hospitals that weren't doing so well to figure out why, you know, what is going on? What do we need to do to fix these? So the data is actually being used, which makes me feel good. So this is a picture of the former Minister of Health of Sierra Leone, Dr. Soka Kabia. And he's former minister because of a cabinet reshuffling. He is now, and he's by training a nephrologist. So it makes sense, he's now Minister of Fisheries. You know, hey, not my decision. But he seems to be doing a pretty good job there. But when he was Minister of Health, we would sit down a lot, and he was very interested in surgical conditions, and it was great. And we would chat about this stuff, and then I would walk out of his office going, I can't believe I just spent 45 minutes with the Minister of Health of a country, because he's got to have better things to do than just to talk to me. But anyway, one of the other things we did was we did send over supplies and equipment, because even though I don't really believe in it, Sierra Leone at the time was, they really had, the Ministry of Health had no money. But the supplies we sent over, we sent the containers, and he was the consignee. Because we said, these are supplies and equipment for your country. We're going to send them to you, and then you take them, and we'll see what happens. And we've sent 2 other containers. But I also want to take this time to talk a little bit about the structure of ministries of health, because it was something that I didn't really know. No one had taught me, even though I got an MPH in international health at a fairly prestigious place, Johns Hopkins. Anyway, and what I realized, what I came to learn was that you have the Minister of Health, but that's a political position. And sometimes they may be a clinician, but often they're not. But it's their job to push through the strategic agenda. Now, underneath the Minister of Health in a lot of these countries, and it's not all the countries, but you have sort of two main arms. You've got a permanent secretary, the PS, who takes care of all the administrative stuff to make sure that things function and the transport and the logistics and whatever. And then you have the top doc, the chief medical officer. And that's really the guy who's making a lot of the medical decisions. And so you really have to sort of interact with both, because you can send a container in, but it's the PS that's going to make sure the logistics are happening on the admin side, but it's the chief medical officer who's going to want to know what is being done and what programs. So it wasn't an important issue. Now in the United States, it's a little bit different. We have a Secretary of Health. And on the right is Secretary Silbius. She's with WHO Director General Margaret Chan there. She's in charge, she's again, politician, but she's in charge of Health and Human Services. I also want to put in a picture of this guy. This is Dr. Niels de la Rey, who is head of the Health and Human Services Office of Health Assistance. And it's part of HHS, but he was also appointed by President Obama to be the United States representative at the World Health Assembly. And I'll get into WHO in a little bit. So pretty key guy, especially Scott, since you're going to do all the work for us to move things forward. Dr. de la Rey is an important person that we all should get to know. But I'm going to go back to Sierra Leone. Okay, and this is Dr. K.S. Dow. He's the chief medical officer. Okay, and I was just in Sierra Leone a couple weeks ago, and Dr. Dow was at Connaught Hospital, and they just had a dialysis unit set up. It was donated by the Israeli government. It's great. There will be dialysis there. Might not have been my choice, but they have it. And I was sitting with Dr. Dow while we were waiting for a generator to be installed, and I said, you know, I'm going to this conference, and I'm going to be talking about working with you. What do you want me to say? And he's like, you know, okay, this is a good opportunity. And he said, really, what I really don't want, I don't want people showing up and asking me what I need. He said, I need everything. Okay, and I make these lists, and I give it to people, and then they say, oh, well, I can't do that, or I can't do this, or I can't get. So he said, I want to know what you can provide. I want to know how much you can provide, and then I will pick and choose. And I thought that was great. I also said, do you want me making appointments with you, or do you want me to deal with TB Kamara, the local guys on the ground? And he said, you know what, deal with the local guys. I'm busy. I said, great. Okay, just wanted to clear the air. So to me, though, that really, you know, not asking, and I've made that mistake also, saying, oh, what do you need? You know, because then I can go back and get it, but usually I can't. Sometimes I can. So anyway, important point. So I'm going to change gears a little bit now. We're going to talk about the World Health Organization, WHO. Who? No. I love doing that joke. I don't know, it's really stupid, but especially to folks that work there. They get so annoyed. But you know, if you're like me, well, you're probably not like me, but you know, sometimes think similarly. You look at WHO, and when I started to work with WHO, or actually before, I should say, before I started to work with WHO, I really had them up on a pedestal. And they're this big organization, they're very prestigious. You know, they're part of the UN structure. The headquarters is in Geneva. And it's a nice building. First time I went, I thought it was really ugly, but it's kind of grown on me. And I went over there in 1998. we were dealing with the issue of landmines, and there was no standardized survey for landmine injuries. And there had been a resolution in the World Health Assembly that WHO should take care of landmines, and they hadn't done anything. And so we had created a draft, and we went there, and it was being run by the Department of Violence and Injury Prevention. And so there was this wonderful gentleman, Claude Romer, who'd been there for about 20 years, with one secretary. And he was responsible for violence and injury prevention for the entire world. Yeah, I mean, it's crazy. Unbelievable. I mean, and what was, at that time, a new guy had just come in, Etienne Krug, Belgian physician, and he helped to revitalize things. And over the years, violence and injury prevention now has a budget of $5 million. They've done road traffic safety. They moved beyond landmines. But I started to learn and interact with WHO. The next slide kind of hurts, because for a while, this was how I described things at WHO. It was the ultimate Hollywood set. There was this big, prestigious organization, but there was nothing behind it, because I didn't really see what was happening. And in the field, they weren't doing anything. But it took me a while to realize that they're not supposed to do anything, okay? We all look up to Margaret Chan, okay? But really, she's running an organization, okay? She works for us. Okay. Now, what's also making her job very difficult, and those of you who still, want to believe that WHO can move things forward and do things, last year the budget for WHO was slashed from $5 billion to $4 billion. Okay, 20% cut. They had multiple firings, downsizing. The other thing to remember is they're based in Geneva, Switzerland. They use the Swiss franc. Most of the donations come in US dollars. The Swiss franc is appreciated by about 35%. They ain't got no money. And it's a big problem. Now, that doesn't mean they can't do stuff, but you have to understand what it is they can do and how that functions. So Margaret Chan, Director General, she kind of runs the show, but really what's above her is the World Health Assembly. And now the World Health Assembly is made up of ministers of health or representatives of the government like Dr. Delaray, who sit every year for a week or so in May, and there's an upcoming WHO meeting May 21st in Geneva. And that's really who makes up the World Health Organization. They're a group that gets together and they provide guidance to the World Health Organization, but really to set standards, a little bit of policy, but not really to do much. But what's interesting is the power behind the WHA, and this is where it starts to get interesting. You've got a 34-member executive board made up of various countries. And now the countries are elected for 3-year terms. These are the guys that set the agenda for the WHA meeting. So by the time a resolution, it's got to pass through the executive board to get to the whole WHA. By the time it gets to the WHA meeting in May, it's a done deal. Okay, there may be some discussion, but it's going to go through. It's getting to these guys that's important. And so this is actually how I've come to look at WHO. And I don't mean this in a bad way. WHO is not the all-powerful wizard, okay? But just like in The Wizard of Oz, the wizard did have some powers, and he could do things. We just need to understand what WHO can do and then utilize it, but not think it's going to be too grandiose. So one of the things we've started to do, to turn the talk to surgery, because this is a surgical conference, for the legitimacy of what we're trying to move forward, which is improving surgical care globally, there has never been a resolution talking just about surgical care and anesthesia. There have been resolutions about maternal mortality, about cancer, about injury, about landmines, but no resolution that says surgery is important. Now, I tried to write a resolution, let me restate that. We had drafted a resolution for a Department of Surgical Care and Anesthesia, but because of the budget cuts, the US was never going to let that through. They told me absolute veto. So the resolution, the way it's drafted now, is more general in nature. Pretty much saying, hey, surgery is important, which I believe is important if we're going to move this forward and start to talk to donors. If you want to go to the Gates Foundation, why would he give money to surgery if WHO doesn't even think it's important? So we've got this draft resolution, it's starting to circulate. This is a list of the current members of the World Health Assembly. Okay, and I put in red the countries that are interested in this resolution. And now Armenia has said that they will propose it, Nigeria as well, Mongolia, and I believe there's a representative in the office, in the audience. She's nodding her head that she approves. And Ray has been instrumental in showing them the resolution. Ecuador as well. In addition to having the English version, can't see that one yet. In addition to having the English version, we do have translations in Spanish, French, Portuguese, and Russian. And this is the resolution that the American College of Surgeons has seen and agreed to, in principle, just to keep Kathleen happy. So anyway, hopefully we can move this forward. One of the things for those of you in the audience, if you know people at ministries of health in some of these various countries, it would be useful to talk to them to try to get them to move it forward. Not all of them will. Sierra Leone is on this list. I've spoken with Dr. Dow, he's the representative. I think because of the US not being very supportive, he doesn't want to upset the US. You know, it is very political, and I understand that. So I'm going to close with something that is the way I look at going into a lot of these countries and the work that I do. Like I said, it's the guys on the ground who are there all the time that are the experts. But when you're going to visit, it's something that's actually in the guest room of my mom's house, saying visits always give pleasure, if not in the coming, then in the going.